And most women, as they get older, the first complaint is, I don't sleep like I used to, okay? Or like you tell me sometimes I get really bitchy, okay?
Yeah.
And progesterone oral have shown to decrease those symptoms.
Hi, everyone. Welcome to the TRT and Hormone Optimization channel. I'm your host, Angie Bassa, and I'm joined today with Dr. Eric Serrano. This is our first ever all-women's hormone podcast. So, Eric, welcome.
Thank you for having me, Angie. Nice to be here.
Thank you for being here. So I posted in the group some questions for you, and I think a lot of the questions that came up were about really the ranges in hormones and when to take them. I think it might be a little bit important for us to get into just say if we take a supplement like estradiol or estradiol. When is it most needed, and when can taking it cause harm? So
okay, I want to tell women I do not use the values as the end of all. I use them as guidelines, number one. Number two, I want to tell some secrets to the ladies. Now, if I'm taking estrogen, and depends you're taking oral, cream, whatever you're taking, it depends on the route and the dosage, of course. I do not want you taking it the day of the test. And let me explain what that is, Angie. If I take a medication today, right, and I check my blood levels right now, my levels are going to be falsely elevated because I just took it, right? Now, if I don't take it today, but I've been taking it 10 days prior to my visit, and I measure my levels, that gives me an idea where I am, truly are. For example, if I'm going to make dosages and levels. If I take 1 milligram Monday and I check my levels Friday, I don't take it Friday, and my levels of estrogen are 1.0, that means that dose is not good enough to maintain my level through the day, because already 24 hours plus the dose, or not 24 hours, maybe 12 hours, I'm already below, so I might get hot flashes still. So that means I have to increase that dose to a higher level. Now, I want to bring another issue. How do I measure? Do I measure through blood, urine, okay, or saliva? And people are going to get disappointed on me about this. I did saliva for, I cannot tell you how many years, and the clinical outcomes were not as I expected, even though I had quote unquote normal levels on the saliva. So I start doing this. I start doing saliva, blood, and urine in a lot of patients to say, hey, I'm going to do this. I get this pill, and I say, don't worry, Eric, I like this. Let me find out. Almost always the blood will always identify the clinical areas, meaning if the blood levels were low, I have symptoms. Okay, if my urine levels were on the borderline, I might have symptoms, but the blood was always much more accurate than the rest, didn't matter what. And I use the Dutch test, and I use the blood test, and sometimes I use saliva test, because I think that the key here is to continue following what you're using. If you're familiar with the saliva test, then use your saliva test. I know them, I understand them because I have to. Do I recommend saliva test? No. Do I recommend the Dutch test? Sometimes I do, but it depends on each case. Now, to answer the second question is what levels. I'm going to talk about American levels, okay? I do not know the Canadian levels, and I was discussing this with Danny, because I say, hey, Danny, I have to go into the computer and check what levels are. And if you're taking estrogen and you are going to check your levels, I go check and I say, okay, your levels are less than 5. Okay, I'm going to use the number 5. And the reason I want to use 5, so everybody remember 5 and 50. So remember 5 and 50, so it's easy. So 5 for estrogen and 50 for progesterone. That's what I like. Excuse me, reverse. 50 for progesterone and 5 for estrogen. Oh my goodness. Hold on a second. Let me think.
50 for estrogen and 5 for progesterone.
Yeah. Okay. And when I do that, I don't say, oh, you're at this level, it's over, first of all. Okay, that is not true. Also, depends how you're taking it. Are you cycling it? Are you cycle the estrogen because you want to have your period? So that's totally different. Okay. How are you? My first question is, how are you doing? Are you having vaginal dryness? Are your breasts droopy? Are they dry? Are they hard? Are your skin affected? How's your sex drive? All those things. How are you feeling more tired because I put you on estrogen and affect your thyroid? So then, based on that, then I will make the decision, Do I add more estrogen? What I'm going to do to you? Now, I also follow the literature, okay? And I have to say, okay, what do I have to do to make sure that you're okay? If I have a person that have heart disease, okay, I prefer to use the oral because the oral has shown to decrease cardiovascular events. The
Okay.
cream and the other ones have not. Not that they don't, but I have not seen the research that says, hey, for sure the cream or whatever I'm going to use decrease it. I know the oral does, okay?
Good point.
For osteoporosis, the gel, the cream, or whatever it works, but the oral also works a little better based on the research. Now, I do want to say a lot of testing have been done with Premarin, which is not a real estrogen, but it's a fake estrogen. So I have to take that data carefully and extrapolate, which sometimes you have to the natural estrogen. Now, if you're a woman that have been 7 or more years without taking any hormones, you're postmenopausal, I will not use oral. And I'm going to bite myself here. The reason is one, the literature says 10 years, but I use 7 years, one, to protect myself as a physician, because I don't want you to have a clot or a stroke or whatever and say, oh, it's because you took the oral, which it depends because Premarin is different than estradiol, okay? Now, can I do this? Can I have a woman that has 7 years without menopausal, then I have her 2 years on the cream or gel or whatever I choose, and then change her to oral? Yes, I have done that.
Okay.
With the cutoff 7, if you have never taken any hormones, never ever done anything, I prefer to start with the cream or gel or whatever your choice, but no oral. Not that you're going to have a stroke, not you're going to have a clot. If you use bioidentical, by the way, I just want to protect your physician and to protect yourself. Now, if you're a smoker, which completely changes everything, okay, smoker have an increase on clotting, all these issues, then I will stick with the cream the whole time because you're being so on. Now, if you quit smoking, eventually I might change you to the oral. So to answer one question. Progesterone. Progesterone, I use oral almost 99.9% of the time.
Really?
Okay? And I'm going to explain to you why. If I give you progesterone, I want to see clinical differences. And most women, as they get older, the first complaint is, I don't sleep like I used to, okay? Or like you tell me sometimes I get really bitchy, okay? And progesterone oral have shown to decrease those symptoms. Now, do I use the cream? Absolutely. I have some people that I have oral and the cream combined. For example, I have the oral from day 1 to 17 or 18, whatever they decide to take it, and I give them a little bit of progesterone because they say, Eric, I get so depressed, I get so awful that I need something. And I give them progesterone cream. I give them 25 milligrams of progesterone cream, and they say, oh my God, I feel wonderful. I have my period. I have no issues, but I don't have the mood swings that I have. So do I use one route? No, it depends on your symptoms again. If I have somebody that is clinically not sleeping, is very moody, then I'm going to use the oral. Now, if you're on estrogen, I almost always use oral. You have to, Angie. This is not me, Serrano, saying this. It's just that the literature says if you have the uterus, by the way, if you're taking estrogen, you should be in oral progesterone. The only one that's shown clinically on the research, not that the cream doesn't do it. I do not know the answer to that. I don't think it does based on experience. But to have estrogen, you always use oral to protect your uterine lining, okay? I just want to make sure that everybody knows that. I don't care who tells you different. Oh, you don't need progesterone, you're an estrogen. Because I see women that come with estrogen to my office, they have the uterus and they're not in progesterone because some doctor told them, oh, you don't need progesterone. That's a myth. Well, you do need the progesterone to protect yourself, to protect you from the side effect of building your tissue. So,
for your bones, even. I mean, you need progesterone.
Absolutely. One thing that most doctors don't ask a woman, and this is a key question, and you should ask your viewers, is, do you have a funny taste in your mouth? People never ask that. And I know you never heard that question, but people with low progesterone, if you ask the woman, have you have a funny taste in your mouth? And they go, wow, now that you mention it, yes, I do. And that's a lack of progesterone, by the way. Always ask, and you will see that answer will come up and say, I never thought about it. Let me go home. And they come back and say, you know what? I do have a funny taste in my mouth. But we don't ask that. I just found out because patients would tell me, I ask all these crazy questions. I say, no, I do have a funny taste in my mouth. So I will use progesterone. Usually the minimum dose that I use progesterone is 200 milligrams of micronized progesterone.
Yeah.
I have used 100. there's always a patient out there that, of course, responds to 100. But out of 10 people, maybe half of a person will.
I do 3, and I find that was the happy medium for me.
Yes, absolutely.
Yeah.
Now, I have somebody right now that is taking 800 milligrams of progesterone per day.
Oh, wow.
Why? She has diabetes. She has all these complications, and 800 is what she responds. She has severe bleeding. She was not diagnosed with endometriosis. She was heavy, and all those things. She's lost weight. She's normal now. But 800 is when she feels good. She sleeps. She has no issues. Her lining is perfect. So I have it at that. One thing I also noticed is in America, I don't know in Canada, now that we have the brand name Prometheum, which is the brand name for progesterone. In America, now they have the generic form of micronized progesterone that either come from China or India. It does not work the same as Prometheum. I have perfect labels, perfect levels, right? Oh, these levels are perfect, 5, 5, 5, 5. All of a sudden, I go 1, 2. Are you taking your progesterone? I swear to you, Eric, I'm taking it. I'm like, wait a second, why are you levels off then? Are you taking it like the same way food? Eric, I have not changed anything. The only thing, I went to the pharmacy and they give me my progesterone. And then when I looked at it, it's made in China or India, and it give me total different levels. And so if you're 200 and you use the Chinese or the Indian, you might need 400. But it's not because it's because your levels are off. It's because the micronization of that particular hormone is not as good as the American version. Okay. So when you write micronized progesterone, which is better, or USP, or whatever you decide to do. You asked me a question also about what do you do with the levels, okay? And again, if I'm going to start with a woman, and I have women that say, I just want to check my saliva, I don't want to get poked, then I'm going to continue the saliva levels, okay? Now, note that I usually will be a little higher than they want on the saliva, because that's where I get what I would say response, okay? Clinical response. My levels are going away, or my symptoms are going away. Now, people always ask me, how come I have hot flashes? Hot flashes mean that I don't have estrogen. No, it's not true. Hot flashes mean you have them, or now the drops on your estrogen are much, much deeper than they used to. So as a young woman like you fly at 500, right? I'm making a number. And all of a sudden you're getting old. Now you drop 100 points, you go to 400. But if you're older, now you're at 300 and you drop 100, that takes you below your threshold. So every single woman have a different threshold to have flashes. So a woman might be 50, a woman might be 10, a woman might be 5. I do not know what level is that because it's dependent. And now most women think, I got a level. Well, how stressed are you? How are you eating? What's life? Are you sleeping? Yeah, what are you doing with your life? So how can I tell you have one level? Absolutely no. I don't have the answer to that, but I like to see a 5 or 50. I give you an idea where I want your levels, and you feel good at those levels. And that's what I try. I mean, that's a guideline, and I want to tell the woman that's just a guideline, just 5 or 50. Remember those numbers, and if you're above that, you should be okay.
So say if someone comes in and they have low serum E2 levels, okay, but they're showing, they have high serum E2 levels, but they're showing symptoms of low E2. Does the high E2 and low E2 mimic one another, the symptoms in a woman?
Yeah, it can, absolutely. It's kind of funny. It's kind of funny you say that. I have people that complain of hot flashes, and I get the levels, and they're, like they're ovulating. So I'm like, whoa, what's going on? Okay, let's look at what's happening. I look at their diets. Are you taking soy? Are you taking things that imitate estrogen that are binding to those receptors? Are you detoxifying? I got to look at all that stuff. And I say, okay, let's look at something else is going on. But you know why it's funny that you say that? You can have those high levels of estrogen, but you don't have enough progesterone, and that's why you're getting symptoms.
It's the ratio.
So it depends. And let me give you a huge sample right now. I have a lady that comes to my office, perfect levels of estrogen, I'm having hot flashes, okay? Okay, what's going on? I put on progesterone, she got worse and worse. Oh my God, I can't sleep. I cannot do nothing. What do you do to me? And I'm thinking, what the hell did I do? And when I asked her about her life, she didn't, it was the first time I met her, so she didn't go too deep into her, she wasn't honest. So the second time I saw her, I said, okay, what's going on in your life? Well, my husband wants to get divorced. I said, you didn't tell me that. Well, I told you my sex drive is down. Well, sex drive and getting divorced are two whole
Two
different,
separate things.
two separate things. Well, what happens is her progesterone, instead of going to where it's supposed to go, it's going to cortisol because she's so stressed.
Steals the
And I know
pathways.
people don't think about this, but Angie, look at this. My progesterone can go either cortisol, aldosterone, or sex hormones. Okay? So I'm going to put sex hormones on the side, so testosterone, estrogen. I'm going to put stress on the side. Now I'm highly, highly stressed. What's my body going to do? I'm going to protect myself. I got to go to stress. I don't want to have sex. I don't want to do anything because you're stressed. You got to go here. So here I did give her progesterone, which actually made it worse because I'm stressed. I'm going to cortisol. I did make it worse. I said, hey, it's my fault. Let's deal with the stress. Now I said, maybe I need to go lower in your progesterone. And actually I went from 200 to 100 milligrams. She said, I feel good again. And I thought I'm going to sleep. I said, maybe because the conversion is, now the progesterone is low enough that the boy said, hey, let me have these little two sex hormones. Let me do what I'm supposed to do. But I also help her to deal with her, are you going to get divorced? What do you want to do with your divorce? Which eventually she said, I do not want to get divorced. And I said, well, you're going to have to work at it. But I have to look at all those things. Also, if I have that person on thyroid, which actually, thyroid helps you actually metabolize hormones faster. And people don't know that. If you have too much estrogen, you might lower your thyroid. If you're taking birth control pill, you might lower your thyroid.
It's
so I got to look at all these things together before I make a decision.
So then that's interesting. So if someone's taking a higher dose of thyroid, do they then have to take more progesterone or?
Yes, absolutely. They might have to. Okay. Or do I lower the thyroid dose? But they're going to tell you, I feel great with my thyroid. Don't touch it. Okay. Then I need to manipulate progesterone. I might have to manipulate estrogen depending on what we're looking for. But the ultimate decision there is based on your symptoms. If you're fatigued, do I want to go up on progesterone or do I want to lower your thyroid? No, you're fatigued. I'm going to leave the thyroid where it is. Let me play with the other two hormones or 3 hormones or 4 hormones, whatever I'm doing at that time. Most people don't use cortisol or hydrocortisone. Okay, very rarely you see this in practice. But I see a lot of PTSD in my office, lots and lots. I see a lot of military people, and those people need help. And sometimes I use cortisol or hydrocortisone, which is the natural form of cortisol. They feel fantastic. Oh my God, I can't get up. Now I have progesterone. Now progesterone doesn't have to go cortisol because I'm already giving it to them. That progesterone goes to the sex hormones. So it's kind of funny how things work. So that's why I don't want the viewers to say, oh, if I take one hormone, everything's going to be fine. Yeah. No, let's look at what the causes, reasons, and symptoms that you have. I don't like to treat only symptoms. I like to treat the cause of the symptoms so you don't have to see me.
Gotcha. Past medical history, how they're sleeping, their stress.
Yes, absolutely.
Whether they took oral contraceptives.
Let me tell you how many questions I ask. It takes me about 40 minutes of asking questions in my practice. So for example, you come to see me, look what I'm going to ask you. How old are you? Where do you go to school? Where do you go to college? What degree do you get? When do you get married? Do you get divorced? Why do you get divorced? Okay, was it your fault? Was the other person's fault? How many children? How were those pregnancies? Were they normal? Do you have any bleeding? Then is your father and mother, are they alive? Are your grandparents alive? Do they have any symptoms? Do you have any brothers or sisters? I go through all that. How, are they alive? Are they having any side effects? Are they not all depressed? That might say, hey, I got to check a VDR or MTHFR on you because your history. Do you believe in God? Because that's going to affect how you're going to feel. Do you smoke, drink? Who do you live with? Believe it or not, this is a stupid question. What state do you live? Because some state has low zinc, low selenium. Some state have toxins on the rivers or whatever. So I got to look at all those things. What kind of work do you do? Do you touch chemicals? I have a guy in my office that works in a paper mill, and he's the one that deals with the chemicals.
SO2 and the paper mills are insane.
Yes, but the guy was fatigued, having all these issues. Nobody can tell him. I said, well, let me check your liver. Oh my God, his liver enzymes were out of whack. And what the hell is going on? I did ultrasound, normal side, everything. I'm thinking, let me check toxins. His toxins it was out of, I said, you need chelation. There's nothing I can do. So I sent him to the toxicology because he had his Teflon. You're not supposed to have Teflon on your body, right? Teflon is why you cook your things.
Pots and pans. What we shouldn't cook with, but yes.
Yes, but that's what people use. And you're not supposed to have Teflon. This guy had Teflon in his blood. I was like, oh shit. you know, you got to go to a toxicologist, get rid of this. By the way, the guy is doing way better, but it's because they clean it out, you know, we're helping him get detoxified and all that stuff. So you have to be aware that not only what comes in, but what goes out and what's in between there that you need to find out. So my history, I asked about diet. How are your periods? When do you start in periods? What drugs have you taken in the past? What drugs are you play with? Because sometimes they take stuff and they don't tell you. All these things, I got to know every single detail of your life. Sometimes I get personal. Sometimes I wait until the second visit for more questions. Sometimes I can tell when the patient is abused by the way they deposit their fat on their arms. And I will teach you that sometime. And it is all crazy. Things that people are not aware of, that I make my students look at the patient before they ask questions. They go, why? Because the way the patient walks into your room, the way the patient crosses their legs, the way the person holds their hands together, the way the person have a tick. I mean, all these things will tell me a lot about the client. That's what I always tell Danny. I don't want to do stuff for the internet because I cannot see those things.
Yeah.
I cannot see the patient is reacting or doing if I'm not face to face with that patient.
And I think a lot of the subjective data that you're looking for is also silent. You know, there's
yes, absolutely, Angie. That is so freaking true. That is awesome. You said that. Silent, because the person sometimes, hey, I'm meeting a stranger. This guy doesn't know who I am. Why would I want to tell him all my life? You know, I have a awesome patient. She's awesome now. She had 13 brothers and sisters, right?
Wow.
And I kept asking her, how many brothers do you have? I don't remember. How can a person do not remember? Eventually, what happens, you know, and you was after me poking. And by the way, she's a professional in the medical profession. Is her sister committed suicide? So she wanted to forget about that. It's been 2 years. She doesn't want to remember her sister's name. She doesn't want to remember how many sisters, because she wants to go home and have a good time with the brothers and sisters. Does not want to remember the number, because that number brings that crying spell. You know, I lost my sister, which is crazy. And she said, nobody made me do what you made me do. I mean, this girl is a good friend of mine now, but it's crazy what happens when you ask questions and people tell you. And, you know, in every room in my office, I have a board, a huge board, and I try to write stuff for the patient so they can actually see it, take a picture of it, okay, so they are aware of what's happening. Something that I allow with some of my patients, I let my patients video the visit. I don't care. I'm not hiding anything. I'm not doing anything. You video whatever you want. Now, make sure that video doesn't escape or gets out, because that's it's your phone. It's your responsibility. You do whatever you need to do with that. And they tell me, man, no doctor let me video the visits. I go, why? I'm just telling you something that you use, that you can go back and say, hey, he asked me this question. This is what he told me. And then you can come back later and say, Eric, you told me this. And I'm going to say no. And then they show me the video. I say, oh, shit, I did tell you that, you know. And that doesn't bother me, because I have an understanding with my patients. I say, no, we are discussing it. I'm not telling you what to do. If you do something stupid, I'm going to tell you you're doing something stupid. I'm not going to do that. But if I do something stupid, you say, hey, Eric, that was stupid. I don't feel better. I said, we're not going to do it again. So it's a learning. I think each patient is a learning opportunity for me, which they teach me something different that I didn't know. So that's why I like it. So that's why. What's your other question, Ange? I hope that answered that question.
That's excellent. Yeah, perfect. So yeah, you answered this, you answered that. So when would you treat a patient with estradiol? Would you, do you, like, more so than not, just treat them with progesterone and not necessarily?
No, not true. Okay, depends on age. Okay, how old are you? You have the uterus, you don't have the uterus, okay? What are your symptoms, okay? And what are you here for? Because if you're there for, oh, my hormones are up, but then later I discover, okay, there's more than
Same
that.
migraines. Someone in their late 30s has migraines around their, like day 21 of their cycle. Same.
Okay,
like
then I will ask very specific, that's a great question, Angie. Okay, now how old is that person? Are they on their early 20s or 30s?
Late 30s. 36,
late 30s,
37.
okay. Are you having your periods regularly? Yes, I am. That tells me that estrogen and progesterone are working, but the levels are not what they're supposed to. That's when I will use urine.
Okay.
I will use a urine there.
The Dutch test.
Like a Dutch test, or I might do the Genova test, in which I look at the whole cycle. What's happening to the levels there? That's one of the few times that you see, Now I can use the urine when I need to. The blood will not give me the answer unless the person comes to my office. Now, I want you to notice this. I have also done this. I have LabCorp is in my office too. So I make the patient say, okay, when are you ovulating? Can you tell? Yes. And then I check the ovulation. I say, come and let's check your levels then, because estrogen should be the highest right at ovulation, right?
Yeah, yeah.
And I said, now we have a level, we know where you are. Okay. I want to get one mid-cycle, right? Like 4 or 5 days before you go into your
Ovulation.
period, right?
Okay.
Now I have
Lucia.
2 different levels on the blood, and then you're gonna come when you get that headache. And all of a sudden I say, oh my God, it is a change on estrogen. It is a change on progesterone. Something happened to you that led to that. Now, migraines are a whole different perspective for me because I look at your diet, food allergies, stress. When do they happen? Timing, duration. Do they affect anything else? Are they affected by position? Are they affected by work? For example, you get the migraines Monday to Friday, but you don't get it on the weekends. You see, I looked at all. I know those are questions that you don't think about it, but I want to know what type of headache it is. We call migraine headaches almost any headache that we don't know what it is. You see what I'm saying? Most women say I have a migraine headache, or they come to the office, it's tension headaches, because the kids. I'm married. My husband has children with another wife. They come Friday, and I get them on the weekends only. See what I'm saying? But is it the headache, or is it the kids that are not behaving and she has to deal with that? So I have to change the situation, not a medication. Now, yes, your answer, yes, I will give that woman hormones depending on what they need. It might be progesterone, it might be estrogen, it depends what they need. If I have to choose between one and the other at that early age, almost always progesterone.
Okay.